Welcome everybody to this session, this CAnD3 Lunch and Learn. We are very pleased today to welcome Dr. Jennifer Dowd, and my name is Amélie Canel-Vallée. I have the pleasure and the privilege of being the director of CAnD3. And so today we will have an interesting look back at demography and data-driven decision-making during the COVID-19 pandemic. From one of the leaders of using data-driven decision-making in this area. So without further ado, let's jump in to our initial slides. So to the next slide, please. CAnD3 is made possible by the partners and the Social Sciences and Humanities Research Council of Canada. And so we really want to thank our partners and thank McGill University, which is our host institution, for this amazing opportunity that we offer here also to our general audience. So please, to the next slide. Considérant que l'Université McGill est sur un emplacement qui a longtemps servi de lieu de rencontre et d'échange entre les peuples autochtones, y compris les nations Haudenosaunee et Anishinaabe, pardon, je suis toujours ravie de reconnaître que nous voulons remercier ces divers peuples autochtones dont les pas ont marqué ce territoire et sur lesquels d'autres peuples se réunissent maintenant. And also to recognize that the spirit of community and that brings us together through CAnD3, through many continents, many countries, across time zones, is one that also is imbued into the spirit of CAnD3. So we are very grateful and honored to be carrying on with this legacy. Next slide, please. So these lunch and learns will proceed as such. So if you have a question, please put your question in the Q&A box. So this is the little one with the two chat bubbles. Put it in there anytime during the presentation. Our team will monitor those questions and will relay them to our speaker during the Q&A session, or raise your hand during the Q&A segment. When prompted, when invited to do so, raise your electronic hand if possible. That will bump you up to the top of our list. And please introduce yourself, and so stating your name and institutional affiliation, and then state your question to our speaker. Next slide. So today's speaker, as I said, I am extremely pleased today that we have Dr. Jennifer Dowd. I have to confess a bit of an academic crush on her work, and the work, not only her standard academic work, but also the little bit less standard work that she has done in leading some of these initiatives, including Dear Pandemic, Those Nerdy Girls. But I am out of order, and I will do the formal introduction now, because just to recognize our distinguished speaker. So Jennifer Dowd is a professor of demography and population health at the Leverhulme Center for Demographic Research in the Nuffield Department of Population Health, University of Oxford. A shout out to also to Melinda Mills, who is a keen member and a keen partner of CAnD3. So this is a dear institution to our unit, and one that we will go and visit in 2025. So that's going to be exciting. Jennifer is interested in how the social world gets under the skin to impact our biology and health across the life course. And so her work has included deep dives into the biology of stress, infections, and immune function, and the human microbiome. So really from cell to society. And in her current 5-year European Research Council consolidated project, she is exploring the reasons underlying the stalling life expectancy in the US, the UK, and Europe. And I've been, again, a fan following that work. So sad to see that Canada isn't in there. I saw your LinkedIn exchanges, so I know a little bit about that is. Maybe we can talk and we can try and help with that. And Jen has also worked extensively on the demography and mortality impact of the COVID-19 pandemic, as well as science communication through international media as a founding member and editor-in-chief of the social media campaign, Dear Pandemic, Those Nerdy Girls. And for this work, she has been honored with the O2RB Excellence and Impact Award from the Economic and Research Economic and Social Research Council, and the Ida B. Wells Public Engagement Award from the Interdisciplinary Association of Public Health Sciences. And it is well-deserved. Follow them, check them out, LinkedIn, X, and probably elsewhere. So I will stop on that and turn it over to you, Jen, and welcome again, and thank you for joining us.
Thank you so much for that very kind introduction. Let's see, can you see my slides?
Not yet.
Okay. Got a strange desktop one.
Starting now.
You
Perfect.
can see now. Okay, great. Thank you for that very generous introduction. The academic crush is mutual. I feel like we've worked on parallel things for many years, so it's great to finally connect. And yeah, really thanks so much for having me for this event. Obviously, our center is connected to CAnD3, so it's really great to have a chance to meet you all. And I know that this particular consortium is centered around training and data-driven decision-making. So I did kind of, especially this time of year, it's been about 4 years since the world changed a lot. I wanted to take the opportunity to reflect on some of my experiences during the COVID-19 pandemic, since that was a moment for a lot of us, I think, when the urgency of making sense of emerging data and translating that into action became very, very real for the first time. And so this will be very much a bit of a personal story of my slice of experience during the COVID-19 pandemic, but it's by no means a comprehensive overview of the many, many amazing efforts of population scientists as well as other scientists around the world during the pandemic. So it's a little bit of a whirlwind tour, about my research, some of it during COVID-19, but also, as Amelie mentioned, my work, unexpected work, is in science communication during the pandemic, from which I have learned a lot. And this particular date, March 13th, is nostalgic for me in a way because it was our last day in the office, March 13th, 2020, and our center was just launching in November of 2019. So we came together in our conference room, and we had been meeting the prior couple of weeks trying to think, how can we help and weigh in on what's happening? And so it was that day that we kind of finalized this paper that we first put out in March, over this weekend, March 15th. And it was kind of the kickoff to what didn't stop being a very intense COVID experience for many, many years. So I'll talk about that paper in a minute. But I'm going to talk about a few examples then of where I think a population data perspective and the type of training you all are getting was really important for understanding the pandemic, and a couple of examples of work that came out of our center that had some impact. And then, we can kind of maybe talk about things that we need for next time and things we could have done better, because it really was trial by fire, and we didn't get everything right. But I think, our voices as population scientists are going to be very important going forward, whether it's a crisis period or not. Let me see, trying to advance. All right. So if you guys can put yourselves back, I guess, in March 2020, you might remember that Italy was the first place really after Wuhan that started to see really high death rates from COVID. And so as we started following this data, luckily the statistics departments, the health departments in some countries were releasing daily data on mortality. And you can see here in this third column, what we call the case fatality rate by age in Italy that was happening in March 2020. And you guys probably already know this very well, but this reflects the number of cases, the number of deaths in the numerator, and then the number of cases are in the denominator. And of course, we know at that time we were not measuring cases very well. These were the people showing up in the hospital already very ill. So these numbers look quite high. But it was alarming to see this, especially in a wealthier country with the good healthcare system. And so even if you didn't take these case fatality rates at face value, one thing that really stood out to us as demographers was this distribution of deaths by age, that they're very concentrated at older ages, and less than 5% of these deaths were under age 60. And so in thinking about why mortality was really high in Italy at this point, it seemed an obvious demographic point that, for any kind of given infection rate, population age structure would have a big impact on COVID severity and mortality across regions and countries. And this was really, again, the beginning before COVID had reached, hardly anywhere in the world yet. It was just rolling out. So really trying to anticipate what the impact was going to be. And so we kind of wrote up a quick preprint illustrating this point. And the day that our preprint came out and we put it up on Twitter, we learned from Monica Alexander that, in fact, every demographer was thinking this very same point. So we really were just stating the most demography thing ever. But we took that, I guess, as a compliment, and it kicked off the conversation about why demographic thinking was potentially going to be important during the pandemic. So this got published a bit later, but it was basically a really simple illustration of stylized examples of two countries, that had not yet been touched by the pandemic, that had similar population sizes but different age structures. And then we kind of assumed a uniform infection rate and the case fatality rates that Italy was seeing at the time. And we could really, show that countries with older, older age populations could expect to see much higher fatalities during the pandemic. And, again, a very basic insight, but other people were making the same point that you could kind of look across local areas in Europe and see where you would expect, particularly vulnerable areas just based on age distribution. And some colleagues, Ilya Kashnitsky and Jose Manuel Alberto, found that the age-sex gradient in infection fatality rates was so pronounced that you would expect a fourfold variation in regional infection fatality rates across Europe, only due to differences in population structure. And so again, these were coming out basically in March and April of 2020, trying to anticipate where the pressure points really would be for resources and hospital capacity and all of these things that we were worried about at the time. And our center also wrote a paper at that time trying to estimate the hospital burden at local levels in England using ONS and NHS administrative data, and then kind of layering on the risks that we knew from age structure, as well as socioeconomic deprivation, and also created an online dashboard where local areas could kind of dynamically look at what their vulnerability to hospitalization risk would be. And this was also something that happened really fast, and we were in communication with leaders in a lot of local areas who were looking for any information that they could get at these really early stages. And, we were also, I was just finding so many examples of how we were reminded early on of the importance of age adjustment, even within countries. And again, these are super basic demographic principles, but that's only because we do this all of the time. It wasn't so obvious to everyone. And this was an example of the raw death percentages for Latino populations in New York City, which was hit very early. That was obscuring actual disparities, because it looked like the percentage of deaths in Latinos was similar to the overall percentage in the population. But that didn't account for the fact that Latinos are much younger, so we should not have been seeing as many deaths. And so I know this is such a basic point, but what I think is worth remembering from being back in that moment was that when a crisis like this happens, there's so much, raw data, raw descriptive data coming out all of the time. And so those of you who are trained to interpret that, even, understanding the basic importance of age adjustment, it ends up being really, really important in real time. And, still, even though this was really important in the very beginning, very few countries were releasing their COVID mortality data with key demographic information such as age, sex, or comorbidities. So that was also something that I think our community pushed for. And Max Planck did create a harmonized database of age and sex disaggregated COVID mortality called the Coverage DB project. So there were real efforts to try to fill these gaps as quickly as we could. Yes, and there were memes to help us, get through this crisis on Twitter at the time. But one of, related to this early data that was coming out, one of the real challenges was trying to, calibrate how deadly COVID really was. Because if you can remember, in those really early days, there was a lot of discussion. Is this, any worse than the flu? And the answer to that question had big implications for how drastic, our restrictions should be. Should we close schools? Ultimately, the much stricter restrictions really relied on understanding how lethal this new pathogen was. We knew very little about it. And so one of the challenges I mentioned earlier was that we knew our denominators were wrong for these infection fatality rates. And, it was very hard to know how many people were actually infected, and thus really hard to actually know how lethal COVID was at first. And luckily, again, I think population, scientists filled this gap within a couple, 2 or 3 months. There were some surveys, seroprevalence surveys, so doing a population-based collection of blood that was able to test for antibodies. Spain did a great one at the national level, and the UK ended up having a long-running, really great population-based surveillance study. But from those studies, we were able to get pretty, accurate estimates of the actual infection fatality rate. And and it wasn't good, but you could also see very clearly, so this paper kind of put all those estimates together, how important age still was, that about 90% of the variation in population level infection fatality rates across geography really was reflecting differences in the age composition of the population, because the infection fatality rate goes up so dramatically with age. And at this time, it then, I think, was very useful to clearly demonstrate that COVID was not the flu. I feel like we're still having this argument, and obviously it's different 4 years later, but this came up a lot, and these are some estimates from lots of different seroprevalence studies, the infection fatality rates that were estimated. So COVID is in red. And just to note on the y-axis that this is a log scale. So you can actually see that, COVID is many, many times worse than flu mortality, and, increases quite dramatically with age, as you can see. So it was really important to, inform policy of how seriously should we take this new threat, and, what types of restrictions are appropriate. And then I'll start here. As you guys probably also experienced in the media, there was also a lot of debate as the pandemic wore on about whether we were overcounting COVID deaths. And I know in the US, this was particularly something that Trump liked to say, that, doctors had some incentives to put COVID on the death certificate, that they were getting financial incentives to do that. And so that people might come in with a, car accident and get coded as COVID. And I think, people believed this. I think the more, fair, kind of reasonable question was, because COVID was hitting a lot of older people, were those people going to die soon anyway? And that's something that we think about a lot as population health scientists is, how much of this is kind of pulling forward by a little bit, the deaths of really frail people versus, a really direct effect of this new virus. So demographers, have some tools to think about that, luckily. And suddenly the concept of excess mortality, which had often been used in disasters, like natural disasters where you're not counting deaths from a hurricane or flood very easily, it suddenly became showing up in the New York Times and the Economist and the Financial Times as the way to really capture the burden of COVID mortality. And the advantage of this was, that whether, it's estimating the number of deaths above and beyond what we would have expected. So it's not counting people who are only coded as dying from COVID. It counts deaths from all causes, regardless of how they're coded, and then compares them to some kind of counterfactual 2020 where we did not have COVID. And I think I wrote about this for Dear Pandemic on our science communication platform. And it was actually a really intuitive, I think, way to explain why we're not overcounting these deaths. And it was, I think the first time I wrote about it was in July 2020. And again, it was one of our most popular posts to date at that time. And people, I think, the comments were that, they've heard this a lot from their family members, and this kind of gave them a very clear way to explain to their family why it wasn't true that we were, overcounting COVID deaths. And so as I said, this became very mainstream, and we started to see excess mortality estimates in the media. And, at least I think it was a very convincing way to show what the true burden of COVID really was, even if you didn't believe in people were getting tested or being coded as COVID. And our group has worked on trying to take stock of excess mortality a bit in both the US and the UK. This is through mid 2020, but I think in the UK, we were at close to 200,000 excess deaths. But you can kind of see that turning point after vaccines came out in the summer of 21, that it's a much more muted excess mortality. Whereas in the US, I'll talk a little bit about that later with vaccines, but it was a very different picture. Even post-vaccine, the US was hit very hard in the Omicron waves, the Delta and Omicron waves, with very high mortality that wasn't seen in the UK. So going kind of proceeding on the timeline. So this was all very early spring of 2020, trying to get a handle on, how lethal COVID was, and to inform what kind of restrictions governments should take. Here in the UK, there was quite a serious lockdown from mid-March to June, I would say. Just gonna take a little sip of water. And so as we started thinking about reopening, our group also was trying to inform strategies that might still limit transmission while society opened. And we had some social network researchers who kind of proposed an exercise to simulate how changing the network structure of people's interactions could allow people to start, having social contact again, but limit the transmission of infections at the same time. And the basic idea of this paper, was obviously that infections are transmitted person to person. So that's why social distancing, made a lot of sense. If you have contact with fewer people, then we were all looking to flatten the curve at that stage. But social network theory had, some insights that it's not only the number of contacts, but also the structure of those networks that can really affect how the transmission goes onward. And I'm hoping I can get this video to play. Okay. So the basic idea here is that even if you have the same number of contacts, a network where it takes longer, there's less bridges between these kind of smaller networks because you're kind of more in these pods or bubbles, ends up leading to less transmission and also flattening that curve over time. And I mean, it's more complicated, you guys, if you guys want to look at that paper. But the general idea was that, we'll have a lot less transmission if these contact patterns look like a social network where we don't have these bridges that will bring in a new infection from someone in a distant social network. So the more bridges between these social networks, the faster transmission happens. And so people can actually strategically choose contacts that would lead to less overall transmission. And there were a few different strategies that were proposed, but the essence of them came down to interacting with the same people. If you kind of have, and you could think of this as workers in a nursing home or a care home, for example, that would be better to have the same group of people on shifts together instead of constantly, shuffling staff, because that would bring all of their networks together and transmit the virus. So these types of strategies, actually got proposed, not entirely based on our paper, because it's kind of, I mean, we did a lot of careful simulations of why this was true, but it's obviously also pretty intuitive. But the research was presented in the UK Parliament, and the UK government, when they started opening up, allowed people to have these support bubbles. So you guys probably had this idea of pods or bubbles, maybe in your schools as well, but a lot of schools, went back in the fall and did this type of cohorting or keeping people in smaller groups to limit spread. And so this was something that Dear Pandemic also kind of recommended in the fall for people going back to school, to kind of keep your social groups small. And that would be something that could limit spread. So this was something that, again, it happened really fast in the spring, trying to think of how we could inform policy about reopening. We knew that we weren't going to stay in lockdown forever. And I think is just a good example of kind of an interdisciplinary contribution of social and behavioral science to things that were happening in real time. And, we were kind of able to have conversations with people making these decisions, not Boris Johnson, but a lot of consulting with universities and other organizations making decisions about going back. And next, I wanted to talk about then by the fall of 2020. And so I'd been working on COVID a lot by this time, and doing a fair amount of both research and media. And I don't know how many of you guys remember or were aware of something called the Great Barrington Declaration, which got a lot of press at the time. And it was 3 academics, Martin Kulldorff of Harvard Medical School, Sunetra Gupta, actually here at Oxford, but not in our department, and Jay Bhattacharya at Stanford. And they, they kind of signed with great fanfare and champagne up in Great Barrington, Vermont, I think, maybe New Hampshire, this kind of document that was proposing a different approach to COVID policy, and what they called focused protection. And they argued that it really was kind of time to go back to normal, essentially, that people who are not over age 65 have very little risk of COVID. So we should kind of let everyone go back to normal and shield the vulnerable as best we can. And there weren't a lot of details in what they were suggesting, but it was taken up, not surprisingly, by some governors in the US who were, thought this was a great idea, and they became kind of the darlings in certain political circles. But these were, 3 academics at the time that were, colleagues of a lot of us. So I remember thinking that this, was definitely something that we should all talk about and take seriously, in the sense of we should be having debates about these trade-offs. And so a pretty big group of scientists came together to reply to this idea. And this is just kind of thinking through a lot of the issues with this focused protection. Because, the idea might sound really good, but the practicality of this, when you dug down into it, had a lot of problems. And I think this is where some of us kind of brought in, demographic exercises and thinking about families and living arrangements and how difficult it would actually be to keep people over age 65 isolated from the rest of society. And so you could do a lot of back of the envelope just about how impossible it would be because of intergenerational households. And also, a lot of older people actually are still working. Obviously, people working in care homes, there's so much overlap that there was no real proposal. I mean, there was actually, these authors suggested, putting people in hotels for 6 weeks, like older people in hotels for 6 weeks. It was really not practical, the things they were, and they thought it would all be over then in 6 weeks, was the other kind of funny part of this. But it was kind of reaching fever pitch, because obviously a lot in certain political circles, people really wanted to think that we should open up and go completely back to normal. So this was the response that I was a part of, that again tried to address very factually the claims that were made in this Great Barrington Declaration. And, it also, it became, it was kind of the beginning, I feel like, of when COVID turned very political. So it was an interesting moment for me, because up until then, I had kind of felt like the scientific community was all in this together to figure out the right answers. But this was a real turning point for me, and a point where I realized that having the good data and evidence wasn't the only thing, because, once science is politicized, that kind of changes the nature of the game, which maybe we can talk more about at the end. So this was in October of 2020. So you might also remember where you were on November 9th, 2020, when the results from the first Pfizer trial came out. I remember it was a Monday night, and we decided to open champagne, because this just seemed like the best news ever, since we'd all been inside since March. And I just remember it being a really moving day and a hopeful day from my standpoint. And a week later, the results from Moderna came out that were equally exciting. And it seemed like there might finally be light at the end of this tunnel, right? But that did lead to our next set of kind of policy decisions that were very important. It only took till December 8th, 2020 for Margaret Keenan in England to become the first person outside of a clinical trial to receive the vaccine. And that was kind of the official beginning of the global rollout. But now the challenge became, after we developed these amazing technologies in record time, how would we best get them into people's arms? And I really found this fascinating as it played out, because it brought home to me how much we had really been doing this all along, but the vaccine rollout brought home to me how much the pandemic was dominated by kind of medical and clinical perspectives, which are obviously very important. when there's a novel virus killing people. But a lot of the issues we started to face were really population-based, questions that I don't think clinicians, had the same perspective on. And this was an example, I think, of that kind of tension. And I'll talk a little bit about that. So the UK and the US actually ended up taking very different approaches to vaccine rollout, kind of on two different facets of this, age prioritization and a delayed second dose strategy. So I know in Canada might have been somewhere in between. I do remember following that decision as well. And so the vaccine trials were very obviously clinical and laboratory based, but now we're facing this population and policy decisions to best allocate these scarce vaccines and maximize protection in the population. And Europe and North America were in the midst of a still really deadly winter surge at this point. So the stakes, were really high to get this right. And interestingly, I don't know that there's population scientists on the UK, Committee for Vaccination and Immunizations that made this decision, but they very quickly, the first couple of weeks, they were following, the original clinical trials for Pfizer had 3 weeks in between doses. So the first dose and then 3 weeks later, the second dose. And the reason for that in the clinical trial was really just trying to get protection as quickly as possible. It wasn't done from the lens of optimizing duration of immunity or from testing, what would be the optimal way to do this if we're trying to give it out to the whole population. So a lot of clinicians were like, we have to stick to what was tested, and that was a 3-week interval. But the UK JCVI came out very quickly and said, we see a high level of protection after the first dose, which we could see a little bit from the trials. And so they decided that they would prioritize giving out first doses with a much longer interval before the second dose to maximize these public health benefits. And to me, that made perfect sense. You could get, you got a lot of the benefit against severe disease and death from one shot. So let's give that to twice as many people. And the interesting thing was that in the US, this was a non-starter. So this, people talked about this a bit in the media. Certain scientists thought this was a better way to go in the US. And it was just never seriously considered. Because again, I think it was this very individual patient-focused thing that, the clinical trial had a 3-week gap. People are going to want their second dose after 3 weeks. We can't tell them that they can't get it from the individual perspective. And the parallel committee in the US was very dominated by doctors. And you can think about in non-pandemic times when you're approving a drug or a vaccine, that individual patient perspective probably makes a lot of sense. But in a pandemic, this was an entirely different question of what strategy would really save the most lives at the population level. And so I think that perspective was really missing in the US. But the second aspect was kind of who should get the vaccine first, and age prioritization, because as we've seen, mortality rates were so strongly related to age with COVID that the UK, decided very quickly, to prioritize quite strictly by age. And this was a figure that they kind of showed to justify that, which basically showed that 93% of people who had died up to then of COVID in the US were over age 65. So it just seemed, obvious that you want to work down from the oldest ages. They did, give vaccines to frontline health and social care workers, but that was much more narrowly defined than it ended up being in the US. And this is a bit blurry, but it's kind of showing how you can avert the most deaths by following that prioritization that they had laid out that was quite strictly done by age. And again, the publication comes a bit late, but these were, if you remember, there were a lot of preprints coming out earlier during COVID trying to get important information out. Some demographers, including Josh Goldstein and Ken Wachter at Berkeley, did modeling that also showed that the age gradient in mortality for COVID was so strong that the best strategy, the best strategy for vaccination was age prioritization, even if you're accounting for the fact that, you might want to protect younger people because they have more years of life lost if they die. That could be one argument for shifting it younger. But their results showed that even when you account for that, the age gradient in mortality is so strong that age prioritization will save the most lives and the most years of lives lost in total. So this type of exercise, I think, was really helpful. But there was some other work in the US by Elizabeth Wrigley Field and colleagues that I thought was really important and probably didn't, get absorbed also into the policies at the time. But that showed that because there were much higher rates of infection among race ethnic minorities in the US, and also those deaths were happening at younger ages, that age prioritization by itself would probably favor, whites. And so there were some equity issues in doing a strict age prioritization in the US. And this figure kind of shows how that age distribution was shifted younger for Blacks and Hispanics in the US. So they were not dying from COVID at younger ages. And a lot of this was exposure from occupations and other things. And so they made an argument that a geographical based targeting would be kind of minimize mortality and be, more attentive to these equity issues. And I think that was really important work. And probably we should have, thought of all of these things a lot earlier. But the US actually did convene a National Academy of Science panel earlier in 2020 to think about vaccine prioritization before it happened. And these were used in the recommendations of the committee that ultimately made the decisions, the CDC Advisory Committee. But they ended up really prioritizing not just frontline health workers, but also a lot of other occupations, as you can see that they list as frontline occupations, and that included teachers and first responders, but also people over age 16 with chronic conditions, which included anyone with a BMI above 25, which is, most of America, as you guys know. So this really rigid age prioritization did not play out in the US at all. And then there were actual really important just health system differences. So I was here in the UK, and because they had very strict age prioritization, you just waited for your notification from the NHS that it was your time to get a vaccine. And there was really no way around that. In the US, at least from all my family and friends, it really was kind of a free-for-all, where if you could get one because you worked at a university or a hospital, even if you weren't a frontline healthcare worker, you were going to try to get it as soon as possible. And then there was all sorts of jockeying on websites, and it really drove kind of the people who were most well connected were able to get their vaccines first. So it was a very different type of rollout in the US, in the UK, partially, I think, because of these policies, and then partially because of the decentralization of the health system in the US. And going back to the other decision, besides age prioritization of delaying second doses, again, I think I already said this, but the idea was there's a tension between individual and population level policies. The UK chose to delay second doses, and the US did not. And we're actually still working on this paper, but you can see that this did play out as a big gap in the percentage of the population at different ages that were covered by at least one dose in the UK compared to the US during the initial months of the rollout. And we're doing some simulations to see how many lives and hospitalizations could have been saved in the US if they had followed the UK policy, and it ends up looking like quite a lot, although because cases were coming down, it was kind of the spring of 21 was a bit of a lull. It actually probably could have been a lot worse if there had been a big wave in the spring. But the next big wave that came, as you recall, might have been was the Delta wave in the summer. And this is where we kind of shift to the bigger issue, which ended up being vaccine uptake and the politicalization of vaccines in the US. And so from the summer of 21 onward, when most adults had already in the UK and US had access to the vaccines, we really started to see death rates diverge. Up till then, it wasn't really that different in the US versus UK. But you could see death rates start to get much worse in the US after the summer of 21. And John Byrne Murdoch at the Financial Times did some great counterfactuals here too, showing, up through the Omicron wave, that the US not only had lower take-up of the primary series, but then pretty low uptake, which are these dark blue in the corner rates from that recommended third shot in the fall of 21, when the Omicron wave was also coming. And this led to many more hospitalizations and deaths in the US than they probably would have had if they had the vaccination rates of other countries. And so these were some of the counterfactuals that people are working on to still see kind of what the cost of some of these policy decisions were. But of course, as I alluded to, in the US, it wasn't just policy decisions. It really was this unfortunate politicalization of the whole pandemic, but also vaccines. And so this survey from the Kaiser Family Foundation, I'm looking at, if you look towards the bottom, you can see that Republicans were one of the groups with the lowest primary series vaccination rates. Democrats are way at the top here. And this was not something that existed prior to COVID as far as vaccine hesitancy. So it was really a sad development. And it led, to really big differences in mortality post-vaccine rollout, which I just find heartbreaking when you think about that. This was a paper that actually was able to get individual level data and voter registration and show the excess mortality in Republicans, was higher after vaccine rollout, whereas it had pretty much been in parallel the rest of the pandemic. And the New York Times just had something this week that showed that this has kind of persisted and gotten worse. So this is an ecological perspective of counties and their share of Trump votes. But you can see this really big divergence since vaccine rollout of the mortality rates. And again, this is just, these are life-saving vaccines. So the idea that politics is driving people to not get them is really disheartening to me. And that politicalization of the vaccines, was a very American phenomenon. You guys can tell me what happened, I guess, in Canada, but compared to other European countries, the data on vaccine take up by kind of extreme political views was just much smaller, kind of non-existent here in the UK. But you can see in the US, there were really, really large differences in vaccination rates by political affiliation. And so, yeah, those were a few examples, I think, where the population data and perspective and training that you all are getting was really important to thinking through some of these policy decisions. I think we didn't always have a seat at the table where we, needed to be in some of these vaccine prioritization committees, and many, many other things. I think a lot of us were trying to get the best information out there. But I think it's something we need to build, in non-crisis time, our presence in all of these kind of institutions that end up making these decisions. So, there were many, many other realms of decision-making during the pandemic, but thinking about a few areas where I think we could have done better, there wasn't a great evidence base for all of these other non-pharmaceutical interventions, such as masks and school closures and, changing the ventilation in buildings, for example. People were really scrambling to figure out how to help and what to do. And I think it was a shame that we didn't have a good evidence base for some of that. So, we have pretty serious respiratory, illness seasons every year, with flu, RSV, and now COVID still happening. So I think we do have opportunities to design and tests, interventions that could help us be more prepared for the future. But obviously, as I've alluded to, I think we showed that the science isn't really enough. We have great science around the efficacy of vaccines, and it turned out that human behavior, kind of dominated, the miracle of that science. And it was really about convincing people to take the vaccine. And so it's not really my area of research to kind of understand the dynamics of that political polarization, the spread of misinformation, but I think that's a big area now of where we need to understand kind of what went wrong in certain contexts and how we can do better in the future and build back that trust in science and trust in government. We learned a lot about the data and surveillance, I think, that we need in a crisis. And, a lot of countries came through with just making their data available much more quickly for mortality and all sorts of things. Surveillance as far as testing the population for some of these infections in a population representative way. The UK had a great survey that they're kind of continuing, at least in the winter, and testing for many different, illnesses like flu, so that we have like a better idea of what the normal dynamics of some of these viruses are. But I think there's still been kind of a retreat from some of that open data and linkages and things that people were happy to do in the crisis. And we need to be mindful of trying to build that infrastructure that we need, for the next crisis. And I'll just end with a little bit of talking about Dear Pandemic, which was the science communication platform that I found myself getting involved with again very early from March 2023. And it was really just a few of my colleagues, friends from the US who started a Facebook page to answer questions for family and friends. And then, we decided we really just needed to dive in, and there was a lot of terrible information out there, but we were going to try to swamp the landscape and, get the good information out there as best we could. So the site was called Dear Pandemic for a long time because it was kind of, you could ask questions like the old Dear Abby columns. But we were nicknamed those nerdy girls by a reader who said that he would trust anything those nerdy girls had to say. So that's been a bit of our brand since then. And it just kind of happened to become an all-woman team and very interdisciplinary. And yeah, it was an amazing experience, but something we were all learning on the fly was how to do this communication to a general audience. But I think a lot of us were trained as population scientists of the original team. And I don't think that was an accident, because what was really required early on was making sense of all these different levels of data that were coming in, the population level, the transmission, what am I supposed to do with my groceries? Should I sanitize everything that comes into my house? you kind of had to look at all of the data and know how to synthesize it from the macro to the micro. And I think that's where kind of population training, is really, really stands out. And so I think it wasn't an accident that a lot of us had that training. And then it really took off on lots of different social media platforms. And we answered a lot of questions, like practical questions about COVID, but also, had some series about trying to get people to understand misinformation and have kind of more data literacy themselves. So that's something we still try to cultivate. And, we did some things on mental health, all sorts of different topics. And we actually, so we're just having our 4th anniversary because it started almost 4 years ago. And we have branched out into other health topics because we kind of want to maintain this infrastructure for having, practical and evidence-based health information that's easily accessible through social media, because that's where a lot of people end up getting their information, for better or for worse. And we do have some merchandise, which some special anniversary merchandise as well, which might have, been a Mother's Day present for Kate this weekend. So check that out if you want some nerdy merchandise. But I'll just end with, for you guys as trainees, really want to emphasize that, even though I know there's not a lot of career incentives for policy or public engagement work in academia, I really hope that we can change that, because the pandemic, taught me how important it is that we're ready to do that, when the time comes, when our skills are really needed. And so I would encourage, all of you to think about this in your training, to learn how to communicate to a general audience, and that you don't need to completely stay in your lane. When the pandemic first started, we thought, let's leave it to the virologists and immunologists. But it very quickly became clear that we needed all sorts of expertise to make sense of the data and information that was coming out. And in today's world, I think, the population perspective and demography is really, really salient to a lot of hot button issues around low fertility and reproductive health, obviously, population aging that a lot of you guys are working on. I really think we need to make the case, for our expertise to be at the decision-making tables. And, to do that, we need to put ourselves out there a bit more, and help each other get into these networks where decisions are made. So I think I will leave it there. Thank you very much.